have now the pleasure, the honor to welcome Dr. Christian Diehl from Argentina to this presentation and to this webinar. Good afternoon, doctor. How are you?
Good afternoon, Stefan. Very well, thank you. And thank you for your introduction, and good afternoon to everybody in Libya. We are very happy to be with you again after such a short time. And today we'll talk about a completely different topic. We'll talk about scars, you know, and healing and scars. And before talking about scars, we must remind the healing phases in wound repair. The first one is hemostasis. There are 5 phases. And let's start with the first one, hemostasis. This is the immediate response following injury. It features vasoconstriction with coagulation. And why? Because there is blood loss, and we must avoid it, you know, of course, and as soon as possible. But this vasoconstriction is positive at blood loss level, but it may have unwanted consequences with increased damage to viable local tissues and ischemia. You know, the name is ischemia reperfusion. And this is a risk of this first phase in wound repair. The second one, which is coming very quickly after hemostasis, is inflammation. Inflammation will be, on the contrary, vasodilation and increased capillary permeability. It's first induced by neuropeptides, and substance P is very important at this stage, and the release of cytokines and adhesion molecules, neutrophil chemotaxis, fibroblast proliferation. All of this is giving birth to inflammation. And also the role of serotonin, histamine, bradykinin, which are byproducts which are causing inflammation. And at cell level, inflammation is not only due to neutrophils, but also to Langerhans cells, also to keratinocytes. Keratinocytes appear like neutral and quiet cells, but this is not the case, you know, in the skin. Keratinocytes are very important constituents of the epidermis, and they are sending a lot of signaling, you know, to other cells, and not only to melanocytes, which are closer, but also to dermal cells. And endothelial cells also have an important role. And as we were telling, keratinocytes, between others, are releasing pro-inflammatory cytokines, and on the contrary, endothelial cells will release more likely adhesion molecules. Angiogenesis is the following phase, which is modulated mainly by soluble growth factors, and especially vascular endothelial growth factor, which is the most important player, you know, in angiogenesis. And these factors, these growth factors, will induce the proliferation and migration of epithelial cells. And as a consequence, next phase, epithelialization, which is the restoration of the protective barrier of the skin. It is mainly regulated by dermal-epidermal interactions, and once more, keratinocytes will be involved. And normally, cytokines release should be reduced because inflammatory phase is over, you know, and we are in another phase, and normally cytokines levels should be restored normal. And this is the moment of the most risky phase of wound repair, of healing, which is fibrogenesis. This is the most critical stage. And this is a very thin, balance between synthesis and degradation of collagen. And it must be very balanced. And it will be okay, and the scar will be okay, and will have perfect healing. But in practical, it's not so easy, and very often there may be unbalance. And after that, what happens? Remodeling. This is the last phase of healing process. It's a continuous process, beginning with the dissolution of the fibrin clot, and it will end with the mature wound, and we talk about 1 year or sometimes 2 years, depending on the extent of the lesion. And at this stage, fibrin and vitrolectin will be replaced by collagen 3, and after that, collagen 3 will be replaced by collagen 1, and we are again in physiological conditions. At this stage, proteases have a very important role, a key role, and we talk about plasminogen activator system, but also matrix metalloproteins, and collagenase, elastase, and so on. And we must emphasize on something important, an important phenomenon in wound healing and characteristic one, which is occurrence of contractions, and this is due to change of fibroblast to myofibroblast, which is a contractile phenotype of fibroblast. And this is very important. We must have it, in order to get a good healing process, but it has a limited time. And if this is too a long time, if myofibroblasts are remaining too a long time, then we can have occurrence of keloids and hypertrophic scars. So, keloids and hypertrophic scars, they are the result of an exuberant fibrosis. And we talked about fibrogenesis phase in wound healing, and if there is an exuberant fibrosis, if fibrogenesis is not limited, we'll see the occurrence of keloids and hypertrophic scars, and this can follow any cutaneous lesion, like vaccine, burn. It's very frequent in burn, and also post-inflammatory after acne or folliculitis lesions. Well, in the mind of the patient, sometimes there is some confusion between keloids and hypertrophic, and we know very well that they are quite different entities. First, in terms of onset, keloids have often a late onset after 3 or 6 months after occurrence of the lesion. On the contrary, hypertrophic scars have early onset, 1 month. The extension of the lesions is maybe the most important thing. Keloids are extensive lesions, and they are not limited to the wound. They may go further, and not limit to the wound, to the lesion size and to the lesion surface, but go much further. And also this, we'll see pictures, these crab legs, which are extensions of the keloids. And on the contrary, in hypertrophic scars, the lesions are limited to the wound surface. Evolution is undefined for keloids. There may be possible spontaneous healing, but it's not very common, and nobody knows which will be the evolution, and usually it's not a positive evolution, you know. And on the contrary, in hypertrophic scars, there is very often spontaneous healing, but only after 1 year or even 2 years. Pruritus and sometimes pain in both, and in keloids, depending on the location, you know. If this is located on joints, you can have a functional loss. So you see very well the difference. This is hypertrophic scar, and this is really limited to the incision, you know, to the place of incision. And on the contrary, this keloid is probably it's due to scratching or spontaneous keloid, and it is going far beyond the place of lesion, you know. There is really a big difference. And you see that keloids may be very invasive. First, they may be multiple and very invasive, and believe it or not, this is the consequence of ear piercing and nothing else. And you see the consequence, but you see also that all these cases are dark-skinned people. And there is a reason for this, you know, because the keloids are much more frequent in dark-skinned individuals. And we must take it into account, you know, when we have dark-skinned patient, we must be aware that there is a possibility of keloid much more than in white-skinned people, in Caucasians. Well, which is the etiology of these pathological scars? As we told it, there is a major role of the anarchic and prolonged release of cytokines. We told about this inflammatory phase. There is a release of pro-inflammatory cytokines, but it must be limited in time. And usually we talk about 2 weeks, 15 days. And if it's more than this normal duration, in this case, we are at risk of occurrence of keloid and hypertrophic scars. TGF-beta, transforming growth factor beta, is very important also. It's elevated in burnt patients, and also it's very low and even not existing in fetal wounds, you know. And what happens, fetal wounds are healing without scars, and there is not TGF-beta. So we can consider, and these are only a few mentions, but there are a lot of them, that the major responsible of occurrence of keloids is TGF-beta. We must take care about this. There is a key role of this increase of TGF-beta. And the bad thing is that free radicals, and we have free radicals when there is a lesion, you know, there is a production of free radicals, there is oxidative stress, and free radicals are increasing the release of TGF-beta by keratinocytes. And on the other hand, the activation, you know, TGF-beta is existing into the skin in a latent form, in inactive form. And upon request, it may be activated. And for this activation, it needs free radicals. So it's like a vicious circle, you know, between TGF-beta, free radicals, and oxidative stress, which is really the reality in any lesion. Well, we have other factors which are elevated in hypertrophic scars or in keloids. We talk about vascular endothelial growth factor. We talked about it. we are talking also about tumor TNF-alpha, which is a very important factor, which is inflammatory factor also, and also two inflammatory interleukins, 1 and 6. There is also not a new responsible because maybe it's 10 years ago, but it was proved that monocyte chemoattractant protein 1, MCP1, which is a chemokine released by endothelial cells, is important also in the occurrence of keloids and hypertrophic scars, as it is increasing fibroblast proliferation. And if we talk about increase of fibroblast proliferation, we'll have more collagen synthesis. And what does it mean? It means occurrence of keloids. Well, we talked about this, about the necessity in the fibrogenesis phase of having contractile myofibroblasts, that normal fibroblast must turn to be myofibroblast, contractile phenotype, but after that, they have to return to their condition of normal fibroblast. And if this is not the case, and if the myofibroblast become permanent, at that time, we may have occurrence of keloids and hypertrophic scars. This is very important. And TGF-beta1 is in favor of the survival of this myofibroblast. Then we must really go against TGF-beta1, against this high level, and reduce it. This is really the only way to get a good result, as well in therapy as in prevention of keloids. Well, the major mechanism responsible for fibrosis and the occurrence of keloids and hypertrophic scars is the production of free radicals, of reactive oxygen species, and this is this oxidative stress that we described. This is also fundamental in the occurrence of these scars. Well, right now, which are the current treatments? First one, we must avoid surgeries, of course. If this is possible, let's avoid them, because it will worsen the condition. At the time of doing it, of performing the surgery, there will be an improvement, but at middle or long term, you will get worsening, because this is another, let's say, aggression of the skin and inflammatory process more, and will get worsening at the end. So let's avoid to any surgery for keloids and hypertrophic scars. Pressotherapy is doing very well, and especially in prevention, and especially in burn patients. But the problem of pressotherapy is first the cost, but also it's very difficult about compliance of the patient, because it's not very comfortable, and they have to wear it 23 hours per day, and really it's not easy for the patient. Intralesional corticosteroids are a simple way and efficient way to attenuate or remove keloid scars. And we talk about intralesional, I mean intralesional injection, and not a cream, because if you are prescribing a cream to your patients, of course the action, the efficiency will be the same. But we talk about long-term treatments, and the cream will not only be on the scar, but also around the scar. And then there will be almost probably skin atrophy and usual side effects of topical corticosteroids. Topical silicones are also a good alternative, you know, and silicones are not active, you know, there are very neutral chemicals, but silicones are making isolation, you know, between the skin and ambiental conditions. And so it's isolating the scar. And then if the scar has no more oxygen, especially, you know, in this case, will improve the condition of the scar. And sometimes, and I know that in North Africa you are doing it, radiotherapy. And radiotherapy, when it's well managed, is giving very good results also. Well, now let's talk about the active ingredient of SODERMIX, which is superoxide dismutase. And superoxide dismutase is a class of enzymes that we can find in humans, of course, but also in animals and vegetables. In any animal or vegetal, we have superoxide dismutase. This is a very classical enzyme and antioxidant. And this is one of the most potent antioxidants. And the mechanism of action, it's working on hydroxyl radical and transforming hydroxide radical to H2O2, hydrogen peroxide. This is not good, you know. If you take into account only this reaction, it's not good. But if you are adding catalase, then you are transforming hydrogen peroxide to water and oxygen, and this is good. You know, finally, this global reaction is very profitable, you know, for the organism, because we are destroying these very strong oxidizing radicals into water and oxygen. Well, superoxide dismutase, because and as a consequence of its antioxidant properties, has also antifibrotic, anti-inflammatory, and antipruritic properties. And why antifibrotic? Because it's able to block the production of TGF-beta. Finally, you know, we talked about it and told we must go against TGF-beta. And finally, thanks to superoxide dismutase, we found an active ingredient which is able to block it, and also able to reverse myofibroblast into normal fibroblast. So we have a very beneficial effect of superoxide dismutase on fibrosis. We have also anti-inflammatory activity, and this is due to the reduction by superoxide dismutase of the migration of inflammatory cells, which are regulating adhesion molecules and expression of cytokines, and as a consequence, reduction in the levels of TNF-alpha, of interleukins 1 and 6, of these adhesion molecules, VCAM, ECAM1, P-selectin, E-selectin. It has really an effect on many cytokines and adhesion molecules, and reduction of the expression of monocyte chemoattractant protein 1 of MCP1. Well, this is a nice explanation, maybe, but it doesn't matter with our patients. You know, they don't need to know how it's working, but they want to see results, and especially in the case of pathological scars, they want to see results. And for this reason, we made a clinical study with patients presenting keloid or hypertrophic scars for more than 3 months. And we had an average of 8 years. So we are talking about quite ancient scars, you know, and not new scars. Using SODERMIX twice a day during 3 months. And the result was first 37% of reduction of the lesional surface after only 1 month. And after this month, 48% of reduction in the volume of the scars. So it's a very rapid effect, you know. And we have some example. You see, when I talked about crab legs, you can see them very well. You know, these small extensions, which are signing a keloid, and this is a keloid and not hypertrophic because there are crab legs. And you see, it's very inflammatory. And after 1 month, we had a much smaller volume and size, and no inflammation, and no more crab legs. You know, there was no more extension of this keloid. And more important, the patient was very happy because from the very first days, pruritus, itching disappeared. This is not a hypertrophic scar or keloid, but this is a hyperpigmented scar. This was 4 years after surgery, you know, and it was remaining very pigmented. And of course, this was a concern for the patient. And you see that in 2 months, we were able to restore a normal pigmentation of this scar. And why? Because it's very simple, because superoxide dismutase is an antioxidant and will reduce the color of the scar, of the pigments. And this case is very interesting. You see, it's quite extensive keloid scar here, and at this place also. And lower, we have hyperpigmentation, and we have like a bad condition of tissue. And this lady had these features, you know, and these keloids for 25 years. So it's a very old scar. And she was not believing about anything. I remember she followed the study, but without any enthusiasm. And after 3 months, maybe she was the one with the best result in the study. And you see that this keloid completely disappeared, and that even at the level of this hyperpigmented lesion, there was a very good improvement. Really, she changed along 3 months. Another case, which is different, it's atrophic scar, you know, and not hypertrophic. You see that there was a loss of substance at this place, and also this was very fibrotic, you know. There was really an intense roughness of the skin. And after 3 months also, always 3 months, we had a very good result, you know. There was some kind of filling of this area, and fibrosis disappeared. And I tell you 3 months because usually this is the length of the treatment. After 1 month, you will see a result, but the result will improve till 3 months, and 3 months is really the gold time, you know, for getting a good result. And after 6 months, I should recommend to stop the treatment because it will not improve anymore. You know, it's only wasting money with the product and nothing else. After 6 months, you can consider that you cannot do anything else and you cannot do better. Other examples, you know, and always we must keep in mind that a very good location for getting good results is abdomen. We have very good result on the abdomen and also on the breast. And you see, this was hypertrophic and hyperpigmented scar 4 years after surgery. And there was no way to remove it. And after 3 months, we were able to remove it completely, as well in terms of volume, you know, of hypertrophic scar, but also of hyperpigmentation. Now we made another clinical study for the prevention of keloid scars following plastic surgeries. And this doctor took 40 patients who were submitted to plastic surgeries, and these patients were at risk of keloids because they had already had keloids, or because in their family there were keloids, and in any case they were at risk. And we used SODERMIX twice a day as usual during 3 months, but as a prevention. And what happened? Among 40 patients, only one had hypertrophic scars after this period. And normally, maybe we could have 50% or something like this. With such patients, really, it was very risky. Look at this guy, and he had a very good result after 3 months, and because there was some tendency, you see, to develop a hypertrophic scar, but after 3 months, we were able to prevent it, and I am sure that this hyperpigmentation also disappeared later. Once more, as I told you, abdominal locations, which are very good. And breast surgery is also a very good indication for SODERMIX. And now we are no more in the frame of clinical studies, but there are separate clinical cases. This lady had a car accident, and besides keloids, she had also this blue pigmentation of the skin, you know, and this is due to the contact between the skin and the tar on the road. And of course, we prescribe SODERMIX in order to remove keloids, and we were very surprised because besides very good results on keloids, we had also a very good results on these blue pigmentations. And this blue pigmentation, we don't know how to remove it normally. And SODERMIX is giving this possibility. So, and this is the other side of the same patient. And you see that on the other side of the face, she had atrophic scar with some loss of substance, and we were able to fill it only with treatment during 3 months, and once again the blue color disappeared. This case also is interesting, and this girl came to see me after 6 months. She went to public hospital and they were not able to get good healing, and she was in this condition, and this girl was diabetic also, and this is of course worsening factor in this case. And I was quite concerned because it was even possible here to see the bone, you know. Really, it was a very bad lesion, and long-lasting lesion. And you see that in only 10 days with SODERMIX, we were able to heal almost everything, and with in very good conditions and very quick relapse in this case. Radiotherapy is a good indication. Also, you know, fibrosis post-radiotherapy. This patient, Susanna, she had this fibrosis for 8 years. When she came, it was 8 years after termination of radiotherapy sessions, and she had quite important and severe fibrosis. And after only 12 days, not even 2 weeks, I was about to tell you 2 weeks, but not even, you see the result was fantastic already. And of course, she continued the treatment, and after a few months, she was perfect. And I know she's going back to the doctor every year for control, of course, and she's still perfect. And when you get this kind of result in post-radiotherapy fibrosis, it's a permanent result, you know. You don't have to continue so much the treatment. Burns is also a very good indication. In this case, this patient was a worker in a plastic factory. He was burned with liquid plastic at 250 degrees, and this was the consequence of the burn. He was treated with silver salt, you know, let's tell a classical treatment, and he had this hypertrophic scar. And we treated this patient during 5 months with SODERMIX, and you see the result. We were able to reduce a lot the appearance of this scar. This patient in Jordan, it was chemical burn in this case also, and he was immediately treated with SODERMIX. And you see that we had an excellent result in terms of scarring, you know, and in terms of prevention of hypertrophic or keloid. But unfortunately, and this is the case with chemical burns, we were not able to avoid this hyperpigmentation, and it's very difficult to deal with after chemical burn. And this one was burned. He was burnt with water only, and you see it was quite a severe burn. And after a short time, we applied immediately SODERMIX. And after 3 months, he was really perfect and with new skin and very nice one, and absolutely no bad side effect after this burn. And this man was working on a gas platform, and there was an explosion on the platform, and he was burned at 70%. You know, it was a very serious case. Of course, with keloids, you know, after treatment, and we started treating keloids with SODERMIX, and we got very good result. You can see here, in 3 months, we were able to reduce it a lot. And even on the fingers, you know, you can see that the fingers are much better after 3 months than before. And this is important because at this stage, this man was unable to use his fingers. You know, you can see it. And this is the product, you know it because you have it in Libya. This is SODERMIX cream. We have 15 and 30 grams, and this is very easy for use. You can use it applying twice a day. It's very simple and very safe, and we don't have side effects. Using SODERMIX is very safe. We have it also, but I don't think in Libya, in patches, and patches are more recommended, you know, in prevention of keloid scars and hypertrophic scars. and you can use them short time after surgery to prevent the occurrence of these scars. And as a conclusion, I should tell you that hypertrophic and keloid scars are quite common and more common in dark-skinned people. And this is a concern for the patients because aesthetically, first, it's not aesthetic. And second, sometimes it may be itchy or painful or even gave some difficulty in movement, you know, and for this reason, they are looking for solutions. And we have solutions, but we don't have definitive solutions in the management of keloids and hypertrophic scars. And any novelty, any new treatment is welcome. And in this case, with topical superoxide dismutase, we are getting very good results as well in terms of prevention as in terms of treatment of keloid scars and hypertrophic scars, and in a completely safe way. And this is very important because we don't like as physicians to deal with side effects and so on. And really with SODERMIX, you will never see any side effect. This is not possible.
Thank you very much, Dr. Christian Diehl, for this nice time we spent together. It's always a pleasure to welcome you for the meeting and the webinars. So thank you very much to all the participants for coming this afternoon and for spending some time with us. Thank you, Dr. Mohamed, for the organization of this webinar locally in Libya. And then clearly we will come again later on with other presentation, other webinar, and other products in the near future in Libya, because it's always a pleasure for us to be in touch with you. Thank you very much, Dr. Christian Diehl, once again.
Thank you everybody, and bye-bye. See you.
Thank you. Bye.